Hello everyone, this is Dr. Kumar Singh. I am an assistant professor in Department of Cardiology, UN Mehta Institute of Cardiology and Research Center. So today we will be discussing a topic that is exercise physiology and exercise electrocardiography testing. So in the introduction part, the exercise is a common physiological stress used to elicit cardiovascular abnormalities that is not present at the rest and to determine the adequacy of cardiac function. The exercise ECG is one of the most fundamental and widely used tests used to assess patients with suspected or proven cardiovascular disease. It also estimates the likelihood and extent of CAD, the prognosis and determine the functional capacity as well as the effects of drug therapy. So we have certain subtopics in this discussion, that is exercise physiology, exercise protocols. We'll discuss about the electrocardiography measurements, non-electrocardiographic observations, exercise test indications, the indication of termination of exercise, specific clinical applications, as well as safety and risk of exercise testing. So in the exercise physiology, the exercise is the most common physiological stress that places a major demands on the cardiovascular system, and exercise is considered as the most practical test of cardiac perfusion and function. Fundamentally involves the measurement of work, and the oxygen uptake is the surrogate marker of the total body work done. And the cardiac output can increase as much as 6 folds. The acceleration of heart rate is due to the vagal withdrawal. There is an increase in the alveolar ventilation, there is increased venous return, that is due to sympathetic vasoconstriction, and in the early phase of the exercise, the cardiac output increased by augmentation in the stroke volume as well as the heart rate. But in the later phase, it is due to sympathetic mediated heart rate increase. During strenuous exertion, the sympathetic discharge is maximal and the parasympathetic stimulation is withdrawn. The vasoconstriction of most circulatory body system, except in exercising muscle, cerebral or coronary circulation takes place. And also catecholamine release enhances the ventricular contractility. As the exercise progresses, the skeletal muscle blood flow is increased, the O2 extraction increases by as much as 3 folds, and the total calculated peripheral resistance decreases. The systolic blood pressure, the mean arterial pressure and the pulse pressure increases. The diastolic blood pressure, although doesn't change significantly. This is a pictorial depiction of the dynamic exercise, all the changes that occurs after dynamic exercise. So there is increased demand of the exercising muscle. There is increased total body oxygen uptake. There is a decrease in the vagal tone. There is increase in the sympathetic tone. In the heart, there is an increase in heart rate as well as increase in the stroke volume, and which is followed by the increase in cardiac output. There is the myocardial oxygen demand increases, the venous return increases, there is an increase in the vasodilation and extraction of oxygen in the peripheral muscles, and there is also increase in the coronary blood flow. So what is VO2? VO2 is the total body or ventilatory O2 oxygen uptake, and is the amount of oxygen extracted from the air as the body performs work. Now the determinants of VO2, principally determined by the cardiac output as well as peripheral arteriovenous oxygen difference. The maximal AV difference is constant, which is 15 to 17 ml per deciliter. VO2 is the estimate of maximal cardiac output. VO2 can be estimated from the treadmill speed and grade with the following formula. VO2 can be converted to the METs by dividing by 3.5. What is MO2? MO2 is a myocardial oxygen uptake, that is amount of oxygen consumed by the heart muscle. The determinants of MO2 are intramyocardial wall tension, the contractility and heart rate. MO2 is estimated by heart rate and systolic blood pressure, that is also called double product. The exercise-induced angina often occurs at the same MO2, and the higher the double product, the better is the myocardial perfusion. So what is maximum heart rate? The maximum heart rate can be calculated by the formula, the old regression equation, that is 220 minus age. We have a newer equation that for males it is 208 minus 0.8 into age, and for females it is 206 minus 0.88 into age. And the MHR decreased in the older persons, and the age predicted maximum heart rate is useful measurement for the safety reasons. So in the post-exercise phase, the hemodynamic return to the baseline within minutes. There is a vagal reactivation, and that is important for the cardiac deceleration mechanism after exercise. This reactivation is accelerated in athletes, but it is blunted in chronic heart failure. So what is metabolic equivalent? It is a unit of oxygen uptake in a resting person or sitting person. It is a common biological measurement of total body work, is oxygen uptake. 1 MET is equal to the resting metabolic rate, that is the value is 3.5 ml of oxygen required per kilogram per minute, and MET value is achieved from exercise test is a multiple of resting metabolic rate. So METs associated with the activity is equal to measured VO2 divided by 3.5. Both values are in ml oxygen per kilogram per minute. So MET is 1 or 2 or 3 or 4. Measured directly or estimated from the maximum workload achieved and used by the standardized equations. So this is a chart showing the clinical significance of the metabolic equivalent for the maximum exercise. So 1 MET is the oxygen consumption during resting phase. 2 METs is like level walking at 2 miles per hour. 4 METs is like level walking at 4 miles per hour. And if the patient has less than 5 metabolic equivalents, so that depicts the poor prognosis. And if it is like 10 METs, the prognosis is good with medical therapy versus the CABG or PCI, unlikely to exhibit the significant nuclear perfusion defect. With 13 METs, that indicates an excellent prognosis regardless of any other exercise responses. 18 METs is like the people with elite and endurance athletes. 20 METs with world-class athletes. Exercise test modalities. So we have basically two types of exercise, the isometric or dynamic, or we can have combination of two exercises. The isometric exercise is also called as resistant exercise, is a constant muscular contraction without movement. It is a high resistant low repetition type of exercise. And another one is dynamic exercise, that is endurance exercise. It requires rhythmic muscular activity resulting in a movement. It also have high repetition and low resistance. So we have exercise protocols. The dynamic protocols are most frequently used to assess the cardiovascular reserve. It should include a low intensity warm up and a recovery or cool down phase. For optimal diagnostic and prognostic purpose, approximately 8 to 12 minutes of continuous progressive exercise is done, and the myocardial oxygen demand is elevated to the patient's maximum effort. So we have different ways to carry out this exercise testing. We have arm ergometry, we have bicycle ergometry, we have treadmill protocol, and we have walk test as well. So what is arm ergometry? This involves arm cracking at incremental workloads of 10 to 20 watts for 2 to 3 minutes in a staged fashion. We have heart rate and BP responses to a given workload, and it is more than the leg exercise. The peak VO2 and peak heart rate is around 70% of the leg testing. Bicycle ergometry involves incremental workloads starting at 25 to 50 watts, and it has lower maximal VO2 than the treadmill. So coming to treadmill protocols, we have a Bruce protocol, modified Bruce, Norton and Weber, ACIP and modified ACIP. The most common used protocol is Bruce and modified Bruce protocols. So every 3 minutes period is used to achieve a steady state before workload is increased. Limitation we have, yes, relatively large increase in VO2 between stages. In the modified Bruce protocol, older individuals or those who exercise capacity is limited, we have this modified Bruce protocol. And what is modification? The modification is like 2-3 minute warm up stages are added. One stage at 1.7 miles per hour at 0% grade, and next is 1.7 miles per hour at 5% grade. So Norton and Weber protocol uses 1 to 2 minute stages with 1 metabolic equivalent increments between the stages. The asymptomatic cardiac ischemia pilot trial and the modified ACIP protocol uses 2 minute stages with 1.5 minutes increment between the stages, and after 1 minute warm up. The functional capacity is overestimated by 20% if the handrail supported is permitted. So we discourage the use of handrail support for a long time. Walk test. We have 6 minute walk test or a long distance corridor walk. It provides an estimate of functional capacity in the patient who cannot perform bicycle or treadmill exercise. old patients, heart failure patients, claudication or orthopedic ligamentation, these patients can be subjected to 6-minute walk test. Walk down a 100 feet corridor at their own pace, cover as much as ground as possible in 6 minutes. Total distance walked is determined and the symptoms experienced by the patient are recorded. The cardiopulmonary exercise testing. It involves the measurement of respiratory oxygen uptake, the carbon dioxide production and the ventilatory parameters during a symptom-limited exercise test. The patient wears a nose clip and breathes through a non-breathing valve. It is more reliable and reproducible measure of VO2. Technique. So, no caffeinated beverage or smoking is done 3 hours before the test. The patient should wear comfortable shoes and clothes. The unusual physical exertion should be avoided. Brief history and physical examination should be performed. We should explain the patient the high risk and the risks and benefits of the procedure, and informed consent is taken. 12-lead ECG is recorded with electrodes at the distal extremities. Torso ECG is obtained in the supine and sitting position. The room temperature should be between 18 to 24 degrees centigrade, and humidity should be less than 60%. The walking should be demonstrated to the patient. Heart rate and BP and ECG are recorded at the end of each stage. The resuscitator, card, defibrillator or appropriate cardioactive drug should be available. So, what is the optimal position of the patient in the recovery phase? So, we should offer the sitting position than the supine position, because the space required is less and the patient are more comfortable, and also the supine position increases the end diastolic volume and has the potential to augment the ST segment changes. So, what are the electrocardiographic measurements? So, we have lead system. There is a modification in the 12-lead standard 12-lead ECG. The extremity electrodes move to the torso to reduce the motion artifact that results in right axis deviation, the increased voltage in the inferior leads, the loss of inferior Q waves and the new Q waves in the lead AVL, and it is also called Mason-Liker modification. So, the types of ST segment displacement. So, J point is a depression is a normal finding in exercise. In myocardial ischemia, the ST segment becomes horizontal. With the progressive exercise depth of ST, the depth of ST segment may increase. In immediate post recovery phase, the ST segment displacement may persist with downsloping ST segments and T wave inversion, returning to the baseline after 5 to 10 minutes. In 10% of the patient, ischemic response may appear in the recovery phase. So, PQ junction is chosen as an isoelectric point, and the TP segment, although it is a true isoelectric point, but it is impractical to choose. So, what is abnormal ST depression? Any ST depression more than 1 mm from the PQ junction with a flat ST segment slope. It is recorded after 80 milliseconds after the J point in 3 consecutive beats with a stable baseline. So, when the patient has a rapid heart rate like more than 130 beats per minute, we measure the ST segment deviation after 60 milliseconds. When the ST is depressed at the rest, additional 1 mm or more during exercise is considered abnormal. So, this is the ECG showing the PQ junction, the ST, the recording of ST segment 80 milliseconds after the J point. So, we have this ECG showing the upsloping ST segment. There is a rapid upsloping ST segment depressed less than 1.5 mm after the J point, that is normal. This is a slow upsloping ST segment at the peak exercise. So, the patient with high prevalence of CAD, the slow upsloping ST segment is considered as abnormal. Horizontal ST segment depression, we can see in the ECG there is a horizontal ST depression in the exercise phase as well as the recovery phase. So, more than 1 mm or greater ST elevation at ST60 in 3 consecutive beats is considered as a normal response. Most frequently with it is seen in anterior MI and early after event, and decrease in the frequency after 6 weeks. The ST elevation is relatively specific for the territory of ischemia. In leads with abnormal Q waves, it is not a marker of more extensive CAD and rarely indicates ischemia. But when it occurs in the patient who has non-Q waves without previous MI, it indicates transmural ischemia. So this is a ECG showing all the 8 typical exercise ECG patterns at the rest and the peak exertion. So we have normal ECG, we have a rapid upsloping, we have minor ST depression, slow upsloping, horizontal can also be seen, downsloping STD changes can also be seen, ST elevation in the non-Q leads and ST elevation in the Q wave leads. These all can be seen in this single ECG. So non-electrocardiography observation include the measurement of blood pressure, maximal work capacity, heart rate response, heart rate recovery, chest discomfort. Normal exercise response. It increases the systolic blood pressure progressively with increasing workloads. It ranges from 160 to 200 with a higher range in the older patient with less compliant vessels. The abnormal BP response is like it is a failure to increase the systolic blood pressure more than 120 millimeter of mercury. More than 20 millimeter of mercury fall after initial rise and they fall in SBP below the resting values. So diastolic blood pressure doesn't change significantly. There are conditions other than the MI, myocardial ischemia associated with abnormal BP response such as cardiomyopathy, cardiac arrhythmias, LVOT obstruction, antihypertensive drugs and hypovolemia. And exaggerated BP increase with exercise shows the increased risk of future hypertension. So maximal work capacity, important prognostic measurement of exercise test. It is the limited exercise capacity, there is increased risk of fatal and non-fatal cardiovascular events. In one series, the adjusted risk of death reduced by 13% for each 1 MET increase in the exercise capacity. It estimates the peak functional capacity for age and gender known for most protocols. So this chart shows on x-axis the years of follow-up and y-axis the cumulative survival. So we can clearly see that if the patient has more than 10 METs, the cumulative survival is more, and the patient has less than 5 METs on exercise, the survival is less. So heart rate response. The sinus rate increases progressively with exercise. Inappropriate increase in the heart rate at low workloads can be seen in atrial fibrillation, physical deconditioning, the hypovolemia, anemia, marginal left ventricular dysfunction. So chronotropic incompetence. What is chronotropic incompetence? There is a decreased heart rate sensitivity to the normal increase in the sympathetic tone during exercise. If enabled to increase heart rate to at least 85% of age predicted maximum, and it is associated with adverse prognosis. What is chronotropic index? So chronotropic index is heart rate maximum minus heart rate rest divided by 220 minus age minus heart rate rest multiplied by 100. It indicates autonomic dysfunction, sinus node dysfunction, beta blocker therapy or myocardial ischemia response. When chronotropic index is less than 80%, it predicts poor prognosis. Heart rate recovery. Abnormal heart rate recovery refers to a relatively slow deceleration of heart rate following the exercise cessation. It reflects the decreased vagal tone and it is associated with increased mortality. So abnormal heart rate response is having less than 12 beats per minute decrement after 1 minute with post exercise slow walking and or less than 18 beats per minute with immediate cessation of movement into either supine or sitting position, or less than 22 beats per minute after 2 minutes. Chest discomfort. Development of typical angina during exercise can be useful diagnostic finding. Chest discomfort usually occurs after the onset of ST segment abnormality. Exercise-induced angina or a normal ECG requires assessment using a myocardial imaging. Diagnostic use of exercise testing. In the patient with CAD, in the single vessel DC, the sensitivity is up to 25 to 71%. In the multi-vessel CAD, the sensitivity is 81% and the specificity is 66%. And in the left main or triple vessel DC, the sensitivity is 86% and specificity is 53%. Non-coronary causes of ST segment depression: anemia, cardiomyopathy, digitalis use, hyperventilation, hypokalemia, IVCD, left ventricular hypertrophy, MVP, severe AS, severe hypertension, severe hypoxia, and SVTN with pre-excitation. are the causes of ST segment depression. Bayes theorem. It incorporates the pre-test risk of disease and sensitivity and specificity of the test to calculate the post-test probability of the CAD. The clinical information and exercise test results are used to make final estimate about probability of CAD. Diagnostic power is maximum when the pre-test probability of the CAD is intermediate, that is 30% to 70%. So this is a Diamond and Forrester chart showing the pre-test probability. It includes age, gender, and the symptoms: typical angina, atypical angina, and non-anginal chest pain. So exercise parameters associated with a multi-vessel CAD. So duration of the symptom, if it is less than 5 minutes, if there is an abnormal BP response, if there is an angina pectoris at low exercise workloads, or if there is ST depression more than 2 mm, that is downsloping, starting at less than 5 minutes, involving more than 5 leads, and running more than 5 minutes into the recovery period. The exercise induced ST elevation in the all the leads except AVR, and if reproducible sustained or symptomatic VT is there. Duke's treadmill score, it was developed by Marks and co-workers. It provides a survival estimate based on the result from exercise test and provides accurate prognostic and diagnostic information. It adds independent prognostic information to that provided by the clinical data and coronary anatomy. Less effective in estimating risk in the subjects with the age more than 75. So that this treadmill risk score can be calculated as the exercise time minus 5 into ST deviation minus 4 into treadmill angina index, whereas the angina index is 0 if there is no angina, it is 1 if typical angina occurs during exercise, and it is 2 if the angina was the reason for patient stopping the exercise. So risk, if the risk is more than 5, it is low risk. If the risk is minus 10 to plus 4, it is considered as a moderate risk. If the risk is the score is less than 11, so it is considered as high risk. So we have specific clinical applications for considering the exercise test after MI. So exercise testing is helpful in determining the risk stratification, the functional capacity for activity, prescription, and assessment of adequacy of medical therapy. The incidence cardiac events with test after MI is low and slightly greater for symptom limited protocols. The submaximal test is chosen. It is performed within 3 to 4 days in uncomplicated patients, and low level exercise test is done with the achievement of 5 to 6 minutes and achievement of 70 to 80% of the age predicted maximum heart rate. A 3 to 6 week test can also be done for clearing patient to return to work in occupation with high met expenditure. Preoperative risk stratification before non-cardiac surgery. It provides an objective measurement of functional capacity, identify likelihood of perioperative myocardial ischemia. Perioperative cardiac events are significantly increased with the abnormal tests at the low workloads, and CAG should be considered with the revascularization following the high-risk surgery in such patients. VPCs are common during exercise test, and it increases with age. 1 to 5% of asymptomatic patients can have VPC with no increased risk of cardiac death. The suppression of VPCs during exercise is non-specific. In the patient with recent MI, the presence of repetitive VPC is associated with increased risk of cardiac events. Ventricular arrhythmia. Exercise testing provokes VPCs in most patients with history of sustained VT. VPCs in early post-exercise phase is associated with worst long-term outcome, long-term prognosis. The RVV morphology type of VPC was associated with increased toward ear mortality than LVV type. Indication for exercise testing in atrial fibrillation patient. If the patient, if the myocardial ischemia is suspected, and initiation of type 1C antiarrhythmic drug is considered to assess the adequacy of heart rate control across the full spectrum of activity and to induce the possible exercise-induced AF. In the sinus node dysfunction, the lower heart rate response may be seen at the submaximal and maximal workloads. The atrioventricular block in congenital AV block, exercise-induced heart rate is low. In acquired disease, the exercise can elicit advanced AV blocks. LVV, the exercise-induced ST depression is seen in patients with LVV and cannot be used as diagnostic indicator. The new development of LVB occurs in less than 1% of patients. The relative risk of death or major cardiac event with new exercise-induced LVB increases threefold. Indicators of CAD in right bundle branch block. The new onset ST depression in V5 or V6 or lead 2 or AVF. There is reduced exercise capacity or inability to adequately increase systolic BP. The exercise-induced ST depression in leads V1 to V4 is common with RVB, but that is not diagnostic. In the pre-excitation syndrome, WQW syndrome invalidates the use of ST segment analysis as a diagnostic method. There is a false positive ischemic changes that are seen. Exercise may normalize the QRS complex with the disappearance of delta waves in 20 to 50%, more frequent with the left-sided than right-sided pathway. Exercise testing in heart rhythm disorder. The class 1 indication is the adult with ventricular arrhythmias with intermediate or greater probability of CAD in the patient with known or suspected exercise-induced ventricular arrhythmias, and for evaluating the response to medical or ablation therapy in exercise-induced ventricular arrhythmias. Cardiac pacemakers. To assess the performance following CRT in the patient with heart failure and ventricular conduction delay, ideal pacemaker should normalize the heart rate response to exercise. ICD. When testing patient with ICD, program detection interval of the device should be known. If the ICD is implanted for VF or fast VT, the rate will normally exceed that attainable during sinus tachycardia. So the test is terminated as the heart rate approaches 10 beats per minute below the detection level. With a slower detection rates, ICD is reprogrammed to faster rate to avoid the accidental discharge during exercise testing that can be temporarily deactivated by a magnet. Influence of drugs and other factors. Smoking reduces the ischemic response threshold. Hypokalemia and digoxin can cause false positive ST depression, so the specificity of the test goes down, although sensitivity remains the same. With the use of nitrates, beta blockers or calcium channel blocker, it prolongs the time to onset of ST depression. It increases the exercise tolerance. Women. Diagnostic accuracy is less in women due to lower prevalence of CAD. The false positive results are common during menses or pre-ovulation or in post-menopausal women on estrogen therapy. In elderly patient, the test is usually started at slowest speed with the 0% grade and adjusted according to the patient's ability. The frequency of abnormal test is more and the risk of cardiac events also more. Subjects more than 75% of age, 75 year of age, the Duke's treadmill scoring system is less useful. In the patient with diabetes mellitus, in the patient with autonomic dysfunction and sensory neuropathy, the inguinal threshold is increased and abnormal heart rate and BP response is common. Aortic stenosis. The exercise testing is absolutely contraindicated in severe symptomatic aortic stenosis. Asymptomatic aortic severe AS ETT can be done to induce either symptoms or abnormal BP response. The abnormal BP response is a lack of increase in the BP or less than 20 millimeter of mercury increase in the BP. If the patient has the abnormal BP response, those patients can be considered for surgery even in the absence of symptoms at rest. In the HCM, to determine the exercise capability, symptoms, ECG changes or arrhythmias or increase in LVOT gradient. Abnormal BP response is considered as high risk. Initial increase in systolic blood pressure with subsequent fall more than 20 millimeter of mercury or continuous fall more than 20 millimeter of mercury from the start of exercise. The high resting gradient NYHA class 3 or 4 symptoms or history of ventricular arrhythmias, these patients should not be tested against the exercise capacity. The safety and risk of TMT. TMT is a relatively safe modality for testing and the mortality is less than 0.01% and the morbidity is less than 0.05%. The risk of major complication is twice when symptom limited protocol is used and the risk is greater when the test is performed soon after an acute event. The early post-infarction phase, the risk of fatal complication during symptom limited testing is less than 1%. So, what are the absolute contraindication to the exercise testing? We have recent significant change in the REST electrocardiogram, acute myocardial infarction within 2 days, high risk unstable angina, uncontrolled cardiac arrhythmias causing symptoms or hemodynamic compromise, symptomatic severe aortic stenosis, uncontrolled symptomatic heart failure, acute pulmonary embolus or pulmonary infarction, acute myocarditis or pericarditis, or acute aortic dissection. There are certain relative contraindication to the exercise testing. Those are left main coronary stenosis, severe arterial hypertension, that is SBP more than 200, or diastolic blood pressure more than 110 millimeter of mercury. There is any tachycardia or bradycardia, hypertrophic cardiomyopathy, or other forms of outflow tract obstruction. If there is high degree AV block, any neuromuscular, musculoskeletal or rheumatoid disorders, or if there is a ventral aneurysm. So the indication of termination of exercise testing includes the absolute indication includes the ST elevation more than 1 millimeter in leads without Q waves due to prior MI. If there is a drop in systolic blood pressure of more than 10 millimeter of mercury, despite an increase in workload when accompanied by any other evidence of ischemia, moderate to severe angina, central nervous system symptoms like ataxia, dizziness or near syncope, signs of poor perfusion like cyanosis or pallor, sustained VT or any arrhythmia that interferes with the normal maintenance of cardiac output during exercise, technical difficulties monitoring the ECG or systolic blood pressure, or patient requests you to stop the test. So what are the relative indications? The relative indication include marked XT displacement in a patient with suspected ischemia, that is horizontal or downsloping ST depression more than 2 mm. There is a drop in systolic blood pressure of more than 10 millimeter of mercury with persistently below the baseline despite an increase in workload in absence of other evidence of ischemia. If the patient has increasing chest pain, if the patient has fatigue, shortness of breath, wheezing, leg cramps or claudication, any arrhythmias other than sustained ventricular tachycardia including multifocal ectopic, ventricular triplets, supraventricular tachycardia or AV heart block or bradyarrhythmias. Exaggerated hypertensive response, that is SBP more than 250 or diastolic blood pressure more than 115, or if there is a development of bundle branch block that cannot be distinguished from ventricular tachycardia. So to summarize, the ECG exercise testing is a mature diagnostic testing modality. It is an important initial diagnostic testing strategy to evaluate the individuals with symptoms of coronary ischemia. It carries the prognostic information for ostensibly healthy individuals, stable CAD, chronic heart failure and valvular heart disease. Thank you.